like to welcome Dr. Weiss for our next presentation on crisis and emergency management with MG. Dr. Weiss is a neurologist who has been in practice in St. Petersburg, Florida since 1993. He graduated from Hahnemann University School of Medicine in 1987. And while in medical school, he became interested in neuromuscular disease with the guidance from Dr. Terry Hyman Patterson. After a medical internship at St. Joseph Mercy in Ann Arbor, Michigan, he completed his neurology residency at West Los Angeles VA Medical Center. He then completed a 2-year fellowship in neuromuscular disease and EMG at the University of North Carolina, Chapel Hill. It was during the fellowship that his interest in myasthenia gravis was guided by the mentorship of Dr. James F. Howard, Jr., also known as Chip. He has had the good fortune to care for more than 1,000 MG patients since beginning his practice, and he has served as the St. Petersburg MDA Care Center Director since 1994. He also participated in the Tampa MDA Care Center from 2001 to 2016. He has served on the Myasthenia Gravis Foundation of American National Medical and Scientific Advisory Board since 1996. And he also served on the MGFA Board of Directors from 2011 to 2020. So thank you so much for being with us, Dr. Weiss. You've got a lot of credentials behind your name, so no pressure. We've got a big audience for you today.
Let me just get this. Thank you for inviting me. You know, as you mentioned, for the past almost 30 years, this has been, well, we take care of a lot of neurologic diseases. This is the one I probably have spent the most time understanding that it's, you know, a lot of times it's reversible or at least significantly treatable. But there are times in which there are issues. You know, we think we're cruising along and then something happens. So the first question that I always get asked is, when should you call your physician? And I kind of divide it up into 2 types of patients. Those that are early in the course of the disease, because you don't have that track record to be able to kind of get a feel for what's your normal or what your normal fluctuations are. And then the experienced patients have a much better idea, and it just takes time. So early in the course, I think with any significant change, I would at least call your physician, especially if you have some of the more serious symptoms, swallowing, speech, breathing. For the experienced patients, you know, often they can get a feel for what's within their realm of normal or their normal amount of fluctuation. But if there are new symptoms, we certainly need to be called. So if you've never had shortness of breath, we probably need to know that. Or if your symptoms are significantly worse than what they usually are, we would certainly, that you should at least prompt a phone call. And then next is, of course, okay, what do I just don't even bother calling my neurologist and just go straight to the ER? I think that has to do with what symptoms they are and how severe they are. So if you have a pretty significant change with your speech, swallowing, breathing, which I refer to as kind of the life-threatening symptoms, just go straight to the ER. And the next, I think that's really the most important thing. If there's a dramatic change, go. Now, if you do call your physician and they say go to the ER, it may sound silly, but you do need to go to the ER. We've had a number of patients who say, well, I decided I could handle it on my own. Got to be careful with that. There's a red flag that's telling us why you need to go to the ER. I also think it's really important to have an advocate, whether a family member, or whoever, a friend, or whatever, to be able to speak for you and know a little bit about your particular symptoms of your disease. Because if you're having difficulty breathing or swallowing, you may not be able to speak with them, and so I think it's really important to have someone else who's able to tell you, to speak for you. So when patients are doing worse, the question is why? And that's kind of important because, you know, there are lots of reasons why you can have clinical worsening. And also, are you having an exacerbation? In other words, not every patient with shortness of breath, for example, has it because of their myasthenia. It could be their heart, it could be asthma, especially if you have a known history of asthma. So could the symptoms be due to any other causes? You know, not all, double vision can be a symptom of a stroke, for example. But again, it's within the realm of what your normal is. It kind of helps us try and figure this out. The other thing is also, are these actually symptoms of myasthenia gravis? Not uncommonly, a patient, oh, I have weakness in my right arm, but I've also got some numbness. You know, for the most part, other than the eyes and the eyelids and eye muscles, myasthenia is relatively symmetric. So if it's affecting one side and not the other, it may be something else. And also the other, are these symptoms actually your typical MG symptoms, or is it something new? You know, someone who's been doing relatively well, has relatively mild symptoms, now they start having shortness of breath and difficulty with swallowing. That's a big red flag. Okay, we've got to really take care of this fairly quickly. Now, there are a lot of conditions, medications otherwise, that can actually provoke the exacerbation of your myasthenia. Probably the most common is infection. It could be as simple as a urinary tract infection, common cold. Any infection can potentially make your MG worse. Thyroid disease, whether it be overactive or underactive, can also worsen your myasthenia. Also, when we look at certain labs, if calcium levels are either high or low, or if you have a low potassium, that could certainly be a potential cause. Now, for myasthenia, the recommendation potassium, because the normal range they say is 3.5 to 5 if you look at the labs, plus or minus a little bit. We actually like the patients to be at least 4.0 within the normal range, because even patients in that 3.5, 3.6 range may actually be a relatively low potassium for them. Also, you know, I'm in Florida, so extreme heat and humidity, certainly we deal with 7 to 8 months a year, and that can certainly make patients a lot worse. But also up north, when you have the extreme cold, when you're sitting in 5-degree weather, that also can make your myasthenia worse. Also, we want to know about what your activity level is. Especially if there's been a significant change in your activity level, that could be the reason why. Poor sleep is certainly a factor. When we treat patients with myasthenia, it's predicated on the idea that you're getting at least a reasonable night's sleep so your body is resting. And so when you're not, it's an issue. Also, there are a whole host of medications that can cause exacerbation of myasthenia gravis. These are usually, you can usually find these online, but it's really important. The one that's becoming increasingly more common are patients are just missing their dose of the myasthenia medication. Some patients missing a single dose of MESTINON can cause a significant issue if they're highly dependent on MESTINON. Missing PREDNISONE, for a day or two might actually be a significant problem. So in terms of medications, we'll talk about the medications that can worsen myasthenia in a minute, but you have to recognize, is that the case? Ones that we think about with myasthenia, has the patient recently started prednisone? You can get two separate issues with that. Some patients, even though it should help patients, in a small percentage of patients, they get what they call a steroid-induced exacerbation, and that is this prednisone actually makes their myasthenia worse rather than better. Also, when the patient takes prednisone for a few weeks and it becomes effective, you may not need as much MESTINON, so that exacerbation of myasthenia may not actually be an exacerbation, but may actually be what we call cholinergic crisis, and that is you're on too much MESTINON rather than not enough. Now, there are a whole host of medications that can cause exacerbation. Now, there are times in which we have to utilize the medications on the list depending upon the type of infection. But when able to use other medications, we prefer that you do that. Fortunately, quinolone, Cipro, and Levaquin should be utilized less in the general community as they're finding more side effects and issues. So it's not as commonly used as it was, but it's still fairly common. Cephalosporins and sulfa medications typically are safe to use for myasthenia. Antihypertensives, including beta blockers and calcium channel blockers, can certainly make myasthenia worse. Now, Norvasc or amlodipine is one that notoriously, in what I've seen, makes patients worse. We also have to figure out why the patient is these medications are being utilized. So beta blockers are also being utilized for cardiac disease. So if someone has a history of heart attack and they're on a beta blocker, we really have to work around that and not have the patient stop, because if your heart isn't working, the myasthenia really doesn't matter. So that's important. Also antiarrhythmics. Virtually every antiarrhythmic that, you know, for cardiac arrhythmia can cause potential exacerbation. You're stuck because, again, if you're not on the antiarrhythmic, that could be an issue with your heart. Now, there are a whole host of medications that have anticholinergic properties. Antihistamines, for example, most but not all of them have at least some anticholinergic effect. The easiest way to figure it out is if the medication causes dry mouth, it's probably anticholinergic. Magnesium supplementation can certainly cause, and I've seen a number of patients. In fact, I've had patients who have take a lot of supplements, and I've had one patient a long time ago. I had them add up the amount of magnesium, and they were on an astronomical amount, more than you would normally take on a normal person would take, even if they needed a replacement. As I mentioned, prednisone as well as other hormones can theoretically make myasthenia worse. Plaquenil or hydroxychloroquine, which is recently of fame with the COVID-19 medication, doesn't work. But for rheumatologic disease, including rheumatoid arthritis, it's very helpful. But I've probably over time, I've probably had at least a dozen patients where they were given Plaquenil where they didn't have a diagnosis of myasthenia, so it's not the fault of the physician, but basically unmasked the symptoms of myasthenia. So that you want to not be on as well. You have muscle relaxants in general are not great. Neuromuscular blocking agents, which we use for anesthesia. There are some of the glaucoma medications. Now, local anesthetics, for the most part, patients can get away with it. It used to be a bigger problem for the newer antiarrhythmic medications for cardiac disease, because we used to use medications like lidocaine and procainamide, which are local anesthetics that we would give it IV to treat the arrhythmia. Those patients would have a significant exacerbation. Botox basically essentially just tries to destroy the neuromuscular junction. Not a good idea. Immune checkpoint inhibitors, which are some of the newer medications that are being utilized for advanced cancers, can cause a myasthenic syndrome as well as along with myositis. But you have to kind of, again, with all these medications, you have to weigh the risks versus benefits. As we mentioned earlier, MESTINON, if it's on too much, can also cause increased symptoms. So then the next question that you have to ask is this really the myasthenia, assuming that they're myasthenic type symptoms, is it actually the myasthenia or are they cholinergic symptoms? Now, the way to try to figure this out is basically trying to figure out how are your symptoms at your peak, how are they at the end of your dose, and are there any other cholinergic symptoms that would give us a clue as to which is going on? So cholinergic crisis basically is due to being on too much MESTINON. Typically, patients will have their myasthenia worse at the peak of their dose, which is about 45 to 60 minutes afterwards. Some patients may be a half an hour, maybe an hour and 15 minutes, but that general ballpark. It wouldn't be at the end of the dose. Also, it could be any of these. So it could be worsening. Also, if you have any muscle twitching at the peak of your dose, that's unexpected. And also if there's unexpected sweating at the peak of your dose. Now here in Florida, obviously, if you walk outside for about 10 seconds, you're gonna have sweating. That's not what we're talking about. Now, occasionally, if MESTINON is overdosed quite a bit, it can actually slow heart rate, but it doesn't happen very often. Other thing you want to look for, are there other GI side effects of MESTINON that may give you the clue, especially if patients normally tolerate MESTINON, all of a sudden they're having a bunch of GI side effects, like nausea, diarrhea. That would be helpful to know. And often this can just be treated by lowering or holding the dose depending upon the severity and the timing of the medication. So there are lots of reasons why one can have this cholinergic crisis or increase cholinergic symptoms. One could be we happen to just increase your MESTINON and you hit your wall and you can't, it's just too far. You just can't go above that dose without having symptoms. We have to live with that and try other things. Also change in seasons. I mean, I have a lot of patients, especially here, who frankly have a winter dose or a cooler weather dose and a summer dose. They often need more in the summertime, but at that transition time, so as we're getting in the next month or two, as we get cooler here, there are probably going to be some patients that are going to call in that they're doing worse, and it's just a matter of having to decrease their MESTINON back to where they were during the cooler months of the year. Now, if your prednisone or immunosuppressant becomes effective, your demand for MESTINON is going to decrease. Similarly, after a thymectomy, when that thymectomy kicks in, that also may decrease your demand for MESTINON. And especially in warmer climates, that can be tricky, because I've had patients where the immunosuppressant or thymectomy kicked in August. And so, you go down that garden path of, oh, it must be the myasthenia, they probably overdid it in the heat, but you got to ask the questions and figure out whether they're on too much or too little. Sometimes after IVIG or plasma exchange, you may also have cholinergic symptoms because, again, they're decreasing the demand. Now, there are some patients that will go either in spontaneous remission or for really no good reason, will just all of a sudden their demand for MESTINON decreases. This does happen from time to time. Now, when you're having a myasthenic exacerbation, the key is at the peak of your dose, your symptoms may be better or be unchanged and worse at the end of the dose. Symptoms typically don't ever get better during that point in time. And crisis is defined as intubation. Now we have a number of patients, you kind of know they're heading in that direction, possibly maybe impending crisis, but the actual definition is being intubated. So with treatment of myasthenia, when you are having issues, you got to figure, what symptoms are worse, why did the exacerbation occur, and how severe is the exacerbation? Those are really the questions we have to try and ascertain, because then we can kind of figure out what approach to take. Everybody is different. So the question is, which symptoms are worse? Now, when it's speech, swallowing, and breathing, that, again, as I mentioned earlier, those are the ones I worry about most. It doesn't mean that I ignore all the other symptoms. I mean, someone could have a baseline of walking a mile a day without any difficulty and now can't walk across a room. Obviously, that's a significant exacerbation, but not a life-threatening symptom. So you put that into our equation in terms of what symptoms are actually being affected. Someone whose eyelid drooping ptosis is slightly worse as their only symptom, that's a little different than someone who can't breathe. So we have to look at those symptoms and kind of figure out how we want to approach that. Now, so why did the exacerbation occur? Is the actual myasthenia worse? Was it a provoked exacerbation, the things I mentioned earlier, infection, medication, those types of things? And if it is provoked, is it easily reversible or not? Now, certainly if it's a matter of overactivity or exposure to heat, basically just getting the patient out of those circumstances may be all you need to do. Also, if there was a new medication added, especially one that we know can cause myasthenia, you just stop the medication. Hopefully it won't take that long to kind of return to baseline. Now, if you have infection such as pneumonia, it may take a little longer to become reversible, or you might have to actually do other things as well. Thyroid disease, even when your doctor changes your medication for your thyroid disease, it doesn't necessarily mean it's going to get better tomorrow. Often, once you replace thyroid, it often takes an order of several weeks to a couple months to kind of get, if that's enough medication or decrease in medication, whichever it happens to be, enough time to become effective. See, that one's going to take a while to get better. Now, the severity of exacerbation is probably, we have to, in our minds, figure out how we go about treating the patient. Again, relatively mild severity, non-life-threatening symptoms, probably don't need to be hospitalized. On the other hand, if there's a severe change in your symptoms, especially the life-threatening ones or dramatic change in your level of activity because of that, then you may need to be hospitalized. Now, one of the rules, I can tell you, when I go to the emergency room, or I get called from the emergency room, they want to throw a high dose of steroids at you, which isn't going to help. Now, the patient's demanding, I need IVIG yesterday or plasma exchange yesterday. Sometimes you do and sometimes you don't. I mean, you know, everything you do has side effects, and so you have to be able to try to figure out, our job is trying to figure out, does a patient really need a rescue medication? Or if they do, should we try, if it's relatively mild, do we try other things first? And if not, we still have the ability to do those medications. So if they're milder or easily treatable symptoms, you know, things like rest, stopping the offending medication if that's possible, correcting the potassium, correcting calcium, treating the infection. You may temporarily have to bump up the MESTINON a little bit just to make sure that the patient's symptoms, you know, aren't going to run away. Again, it depends on what kind of infection. A mild urinary tract infection, not as big a deal. Someone has a pretty significant pneumonia, that's a little different discussion because obviously you're going to get shortness of breath, and you may not know whether the shortness of breath is from the infection and or the myasthenia. So if the symptoms, again, are more severe or more serious, I would still use the strategies I just mentioned. And then you have to figure out how best to treat the patient. So, I mean, the easiest thing to do if you're going to adjust the medication the patient has is to slowly adjust the MESTINON. And you have to go slow. I mean, MESTINON, you'll know in a few days whether it's that particular dose is going to be effective or not. But you can't just crank it up. I've seen patients been sent in from elsewhere. They're on 60 milligrams 3 times a day, and the next thing they're bumping them up to 124 times a day. There's a high likelihood the patient could have probably gotten away with the dose somewhere in between those. And then you also then run the risk of trying to figure out, is it now cholinergic or is it myasthenic, the symptoms that are remaining. You have the ability to add or adjust prednisone, but understand it's going to take on the order of weeks to become effective. So that's you have to kind of weigh that. Now, if someone's already on prednisone, then you might try that, especially if you know that your plan at that point will be to have them increase it anyways, given the symptoms that they have, especially if you feel like the disease is just getting worse. Now, adding or adjusting immunosuppressants like EXACERBATION, Imuran, those types of medications take on the order of months. Now, one of the things that people love to do is say, oh, we're going to increase the MESTINON, we're going to increase the prednisone, now we're going to add CellCept all at the same time. You may or might not have had to do that. So I discourage trying to adjust a bunch of medications all at the same time. Also, you don't know what works. Plus, if there's an adverse reaction, which one is the one that caused it? And then for the more severe and serious symptoms, then you have to decide whether to use the acute therapies or what we call rescue therapies, that is plasma exchange or IVIG. Now, if you look at studies at day 15, there's really not a difference. Now, IVIG is usually given a loading dose over 2 to 5 days, but you have to be careful of contraindications, which we'll talk about in a little bit. Plasma exchange is every other day. Generally, you get 5 or 6 treatments, and we'll discuss how I go about deciding how much in just a minute. I found that overall, I think plasma exchange typically you see benefit a little bit quicker. And if patient's intubated, you want to wait 10 days. If I could have gotten you off the tube in 3 or 4 days. So I'm more likely to try and do plasma exchange if I have a choice. Now, if someone has an active infection like a significant recurrent pneumonia, plasma exchange really is not an option because you get to spread that infection everywhere if you do plasma exchange. So that's kind of important trying to make in your decision making as to what medication to use. Now, for most patients, and this is the thing you have to enter into your equation as well, is most patients, if you get plasma exchange for acute therapy, especially if you're on no immunosuppression of any kind, then you're likely need to get prednisone, and I'll explain why in a minute. So again, our choices, we have MESTINON, which is symptomatic treatment. So this is not treating the underlying disease. Again, a few days to a week, you'll know how you're doing. So we can then decide whether or not how you're doing. I have some patients who come in, I'll wait a few days, adjust their MESTINON a little bit, especially if I don't think it's a particularly severe exacerbation, to get away from having to do IVIG and plasma exchange, which obviously prolongs hospitalization, but also they have potential side effects. I typically recommend that patients take MESTINON after they eat to avoid the GI side effects. As I mentioned earlier, you want to adjust that dose slowly. Patients, again, you don't want to crank it up. And as we mentioned earlier also, the peak of the dose, again, is 45 to 60 minutes afterwards. Now, wearing off is variable depending upon the patient. Some patients it lasts 3 hours, some doesn't even last 3 hours. I do not like to give MESTINON any more frequently than every 3 hours. Then you're on a higher risk of cholinergic symptoms. And of course, those of you on MESTINON, a lot of you probably have experienced at least the GI side effects. You get nausea and or diarrhea. Now, it doesn't completely eliminate it, but then by taking it with food or after you eat, not during the meal, I should say, eat breakfast, for example, then take your dose. I think that significantly decreased the chances of GI side effects. And again, as we mentioned before, the cholinergic crisis symptoms, which again, you would expect symptoms at the peak of the dose. If your myasthenia gets worse, muscle twitching, sweating. Now, prednisone, you're treating the underlying autoimmune disease. Now, typical starting dose is 20 to 60 milligrams a day, but should not be more than 1 milligram per kilogram per day. So if you weigh 110 pounds, that's about 50 kilograms. You shouldn't be getting a dose of more than 50 milligrams a day. Now, patients who are overweight, you want to use adjusted body weight. But typically, I don't like to go greater than 60, other than rare circumstances. You know, the 6'8", like 200-pound person, I might go to 80. You know, they're not for obesity; they're just big. So that, you know, they're just muscular, and you know, that you think of the offense, you know, some of the athletes and those types of patients. So again, I usually recommend taking the prednisone with breakfast in the morning. Again, it takes 3 to 4 weeks to become effective. So you have to understand that expectation. We have patients who are not uncommon, call us a week later, you know, say, well, my prednisone hasn't kicked in yet. And are you taking it good? Keep going. Give us a call back in 2 or 3 weeks, as long as your symptoms aren't significantly worse. Now, if you need any surgery or significant procedure, patients on prednisone need a stress dose on the day of and often the day after. So for example, if patients going for a thymectomy and they're on prednisone already, we'll give a dose the day of and the day after, because your adrenal glands are not going to pump out any cortisol, and you need that extra steroid to avoid what we call an adrenal crisis. So again, if you're choosing prednisone, you have to understand all of these things as well as their side effects and those things in order to determine what you think is the best next medication to give when the patient's having their exacerbation. Now, I'm not going to go through the whole list of side effects because I probably need another 12 slides for that. But basically, I mean, the ones that patients complain about are weight gain. It affects the bones, it affects your stomach, it affects sodium, potassium, sugar. You can feel a sense of feeling lousy, and it does increase your risk of infection. You know, during this pandemic, we have to at least weigh the risk of prednisone, increasing your risk of infection against its potential benefits. You got to think about that. You know, patients who are unvaccinated, it's a much more difficult decision. Even though they're vaccinated, it still may not be sufficient immunity from that. But if you've already had it for a while, you might be able to get away with it. I mean, I don't know. I think in Florida, I think if a prednisone dose is 20 milligrams a day or more, they're considering the patient to be immunocompromised, and as such can get their booster. But yeah, you have to be really careful. Now, IVIG, which is mostly immunoglobulin G, they pool human serum and they treat it to make sure there's no infections and those types of things. And there are several indications. I mean, the one we're talking about today is for an acute exacerbation. And that is a potential choice. Sometimes we'll use it if there's contraindications to other medications, or if you've been refractory to other medications. You know, not every medication works in every patient. I had a number of patients say, well, the IVIG didn't work for me. Well, you may be one of those patients, it just doesn't work. Doesn't mean you don't have the disease. It becomes a little more concerning with patients who are seronegative, because that allows the physician to then start worrying about, do they really have the disease or not, despite the fact they have 12 symptoms that match the disease and make perfect sense. Sometimes we'll also add IVIG if you're kind of hanging in there okay, but you're still having enough symptoms. We may use that as a temporizing measure until the other medications become effective. And again, the loading dose is 2 grams per kilogram over 2 to 5 days. I usually like 3 to 4 days, depending on what the size of the patient is, and then 1 gram per kilogram every 3 weeks. Now, side effects for IVIG, and you have to think about these again if you're making these decisions. I mean, headache is not uncommon. You can either hydrate the patient or add solumedrol, often works. Renal failure, it's known to be, they're going to be on hemodialysis definitively for the rest of their life, then you potentially could use it. Otherwise, patients with renal disease should not get IVIG. It's a big protein load. I mean, I've had a patient in the last several months where they were just put on dialysis. That's not the patient I want to give IVIG, because I may ruin any potential chance they have of coming off of it. So I'd rather not. White blood cell count, not uncommonly, will be low with IVIG. We keep an eye on it. Most patients do not need to be stopped because of it, though. Some patients will get nausea and chills. We can use medications for that. I mean, because often some of the medications have to be stored in the cold, and that's probably the reason why. There is a small but defined increased risk of vascular disease, whether it be heart attack, stroke, peripheral vascular disease. Certainly for heart attack and stroke, I don't recommend it, because if you've already had an event. Peripheral vascular disease, for the most part, I don't recommend. There are occasions, depends on what the circumstances were. Aseptic meningitis is usually related to the rate of administration of the IVIG. So even though you've had aseptic meningitis once, they can just slow down the rate of it, and you might be able to get away with it in the future. Anaphylaxis, which is a severe allergic reaction, obviously, that patient probably is not getting IVIG in the future. You can get skin abnormalities, something called dyshydrotic eczema on the palm, it's on the palms of the hands, and volume overload. I mean, we try to use a 10% solution rather than the 5% solution to try and diminish the likelihood of that. So someone who might have congestive heart failure baseline, you got to be worried about whether that volume overload could be significant for them. And then with plasma exchange, what people call blood washing treatment, basically you're exchanging serum usually for human albumin. On occasion, we use fresh frozen plasma if we're anticipating surgery. Again, and plasma exchange is used for acute exacerbation. Again, my favorite choice if I have a choice. I do use it occasionally for maintenance treatment in patients who are have refractory myasthenia, and also in those in which IVIG is contraindicated. Now, we recommend treating every other day. You don't need to do it every day. Every other day is fine in the hospital. Now, we aim typically for an IgG level of less than 200. IgG is the most common immunoglobulin or antibody in the body. And the reason is once you get that low, the likelihood of getting additional benefit isn't very high. On the other hand, so some patients may only need 3 or 4 plasma exchanges. Now, a lot of people say, well, we're just going to get 5 no matter what, which tends to be about the average. But I had some patients, where their IgG level started high and took longer than average to come back down. And they've had 5, 6, 7, even 8 plasma exchanges with improvement of their symptoms with each additional plasma exchange. One of the keys I learned is that we also need to add calcium into the mix with the plasma exchange. And the reason is if you don't, you actually will get a relative hypocalcemia. That is, your calcium levels will drop. Sometimes they'll drop below normal, but sometimes it could be, if for example, your calcium is high normal, it may drop to low normal, but you still may be symptomatic. So we have to make sure that's the case. It's become much more common. When I first started in practice, in fact, I'll admit my first patient, I didn't realize the first treatment, they got worse afterwards. And I go, how much calcium did you add? And they go, you have to actually order it. Where I'd been in training, they pretty much just did it. So lesson learned, but important. Now, with plasma exchange, you can get infection, especially whatever site that they're using for the plasma exchange. Often we use what we call a Quinton catheter, either in the neck or just below the clavicle, collarbone. But you have to make sure there's no infection. The real watchful eye. Again, if you don't give the calcium, you have to worry about the weakness. The reason that we use, I commented earlier when I said that if prednisone, and if you do plasma exchange, you're pretty much obligated to at least put the patient on either some degree of prednisone or immunosuppressant. If they're already on immunosuppressant, you don't necessarily have to change the dose. But if they're not on any medication, the prednisone is needed to avoid antibody rebound. So what happens is your antibody levels drop really precipitously with plasma exchange. And in about 2 to 3 weeks, they rebound. I've had several patients who I've seen for second opinions, and this has been the issue. They said, I did great for the first 2.5 weeks, and all of a sudden I bottomed out. They didn't give the patient prednisone, and that's the reason why. So when you're considering plasma exchange, you do need to consider whether that patient's going to be able to take prednisone or not. Typically, I'll use 20 milligrams a day. Occasionally, I'll use 10 milligrams a day. And we're finding increasing challenges with vascular access. Now, there are a variety of accesses. There's access you can have. Basically, there are ports, there are tunnel catheters, there's vascular things like in the arm. It looks very similar to what a dialysis patient would be. So when you're trying to figure out plasma exchange versus IVIG, you have to kind of figure out where you're headed. Now, if I know that if I know the patient well enough, and I go, this patient's going to get this patient's probably going to need to get IVIG after discharge, then don't do plasma exchange. Do the IVIG. At least that loading dose will be on board. So you have to use a little bit of common sense and try and figure out what's going to be best for the patient overall. Now, depending upon the individual patient, there are a whole lot of things you have to consider. So if you have diabetes, prednisone, for the most part, isn't a great choice, although on occasion we'll have to do it. But you want to put that into account when you're trying to make your decision. Now, if the patient has a diabetic issue related to their kidneys, you have to also think about that as well. I mean, high blood pressure, again, some patients, if you already have significant and poorly controlled high blood pressure, prednisone may make them worse. As I mentioned, renal failure, I had mentioned that earlier, obviously because IVIG is not a great choice. Liver disease, there are certain medications. I'd be a little bit hesitant with prednisone. I'd be even more hesitant with Imuran. CellCept, you still feel a little bit worried about, but not as much as the Imuran. Also, whether or not the patient has any of these cancers, melanoma, leukemia, lymphoma. If you have those, you should not be on Imuran, CellCept, those class of drugs. It may actually perpetuate it. And the last thing you want to do with someone with leukemia or lymphoma is lower their, adjust their blood counts and adversely affect those diseases. Again, peptic ulcer disease, you have to be worried about diabetes, but also some patients, CellCept can bother their stomach on occasion, but probably better than prednisone. Again, if someone is significantly obese, you want to stay away from prednisone. Excuse me. Again, swelling at baseline. IVIG is not a great choice. Prednisone is not a good choice. Similarly, osteoporosis with prednisone. Also, you have to figure out if someone has an acute infection, again, we would not use plasma exchange. Don't like to treat patients with IVIG, but if I have a choice, that's the one I'm going to use. Also, as you're making your choices, do patients have chronic infections? Obviously, if they have something like TB, you're going to avoid as many of the immunosuppressants as possible. Some patients have recurrent pneumonia, recurrent urinary tract infections. So you have to be very careful with deciding which medication you may want to use beyond MESTINON. Again, as I mentioned earlier, vascular disease. Again, you don't want to, IVIG, you don't want to use that. Pregnancy, we try to avoid the immunosuppressants as much as we can. Theoretically, you can use IVIG. MESTINON should not be an issue. Also, what other medications is the patient taking? That may also impact what you can give. And of course, any abnormal blood counts also may be a factor here. So you have to weigh all of these factors as you're trying to make the decision as to what regimen to take. So even though the patient came in with an acute exacerbation, in your mind, you have to think very acute, those next few hours, next few days, next week, next 2 weeks, but also you have to keep an eye on what am I going to have to do with this patient long-term from a medication standpoint to try to help them, do best with their disease. So I think this is our last slide. So as I mentioned earlier, Dr. Chip Howard at UNC Chapel Hill. This is his famous quote that the only thing predictable about myasthenia gravis is its unpredictability. So it's so easy to, I mentioned, to go down that garden path saying, oh, patient's doing worse, it must be their myasthenia, but forget about the fact that it could be, they may need less MESTINON rather than more. And even though there's an algorithm we have in our mind, there's no cookbook for the treatment of myasthenia in each individual. The treatment has to be individualized given all of your medication, diseases, your previous experiences with medications, and then we can make a decision as to how to best treat you. So I think that's all I have. Thank you. Mm-hmm.
We do have some questions for you. So let me see here. They were Pfizer vaccinated 4 weeks after the last dose, developed an eye droop and diagnosed, progressed till where they have severe muscle weakness right now. They were on 60 milligrams of prednisone, and now they're on 40, and they had a booster on August 18th. They were wondering if this, how has this affected the COVID immunity status, do you think? Are you seeing that from Steve?
Yeah, no one knows definitively how much the different immunosuppressants affect the immunity status. We have to presume that there's got to be at least some impact on your immunity. Mm-hmm. I mean, how long before how long were you vaccinated before you were on these medications? I mean, unfortunately, there are a lot of patients that were already on these medications when COVID decided to pop up. But those that we start a medication, my preference would be to have the vaccinations completed at least a couple weeks with, and Rituxan is usually they think of 4 weeks before starting it, if possible. It doesn't mean that you can't. I mean, some patients, they came in with an acute exacerbation, and you have to do what you have to do. So again, depends on the circumstances, but we have to assume that there's probably not, the immunity probably isn't quite as good if you're on immunosuppression, but I can't tell you to what degree.
Okay. Do you tend to find seronegative patients more refractory or severe?
Well, first of all, it depends upon, I mean, and seronegative, I mean, probably should be changing our definition a little bit.
Okay.
And only in the sense that now we have MuSK antibody. I'm assuming that means, in my mind, that means someone who's MuSK antibody negative And now, since it's readily available, LRP4 negative. I've seen the whole gamut. I mean, and I really have. I mean, even with, post-thymectomy, I've had some patients, seronegative post-thymectomy, did really, really well. Either minimal manifestations or went into remission. We don't know all of the mechanisms that cause myasthenia.
Okay.
We know the ones that we can define and we can test, but we don't know all of the mechanisms.
Okay. Is there a steroid alternative to prednisone if the side effects are affecting multiple systems and yet I cannot manage my MG without steroids on board? I'm refractory using NIV, Cellcept, MESTINON, PLEX, and SCLG. Side effects include hypertension, hyperglycemia, fluid retention, bleeding issues, and potassium deregulation.
I'll try. Okay. So first off, all of the steroids essentially work the same, whether it's prednisone, Medrol, Solumedrol, Decadron, they all work the same way with the same host of side effects. Now, again, as you're deciding to start the patient on those medications, obviously that has to be taken into account all of the other issues as we talked about. But those that may have developed things after the fact, we try to optimize the other medications and try to taper off. But sometimes it's a challenge because if the patients are still significantly symptomatic, you hate to taper prednisone unless you absolutely have to, because the likelihood is it's probably going to make you worse. So we have to weigh all of those things. For example, I have patients, again, Florida, our extended summers. I try not to taper their prednisone during the summer months unless I have to, because if they get worse, I have no idea whether it's because they've been outside or whether it's the prednisone. And often when you then have to increase their dose of prednisone, when you go back, say, well, now we got to adjust your prednisone, often you don't have to go just back to where you started, but maybe a step above that. So the patient who dropped from 20 to 15 may need 25 or 30. Okay. So we have to be a little bit careful in making that decision.
Okay. This person says they were told by an MG doctor quite a few years ago that MG patients were developing a neck brace since we know what we want. Have you heard any news on anything like that?
I'm sorry, try that again. I missed that.
This person was told by an MG doctor quite a few years ago that MG patients were developing a neck brace since we know what they would like for comfort level. Is there anything new on the market that you are aware of that would help neck drop?
Well, the real answer is treat the disease. The challenge with neck braces is that if you use it on occasion, it's probably not a big deal. If you use it too much, then basically your neck muscles aren't being utilized, and actually you may worsen your neck muscles. Okay. So, worsen the strength of them. So you have to be a little bit careful in terms of when you decide if you're going to do that. There are not very many MG patients who I've recommended it to in general.
All right. We have someone that typed in that they're scheduled for their next IVIG on Wednesday of this coming week. And they have been on this treatment since February 2016. I'm also planning on getting my Moderna booster on Saturday. Is that too soon to get the booster?
So the booster after the IVIG?
Yes.
If they've been on it for, if someone was new, I probably would have them wait a little bit of time just to make sure that they have an adverse reaction. But if they've done well with the IVIG, I'm not sure there's any recommendation in terms of timing after IVIG. Okay. I would say with plasma exchange, I would probably have patients try and get it just after especially if they're getting it on a regular basis in an outpatient. I'd rather have them get their vaccine right after their plasma exchange. So, because otherwise, if you do it, if you on a Wednesday you get the vaccine and Thursday you have plasma exchange, you're going to probably knock out quite a bit of the vaccine.
All right. They also said that they're on Imuron in addition to the IVIG. Mm-hmm.
Right. So again, what degree of immunity it confers, we don't know. One comment I would make, though, is that antibody, in terms of COVID antibodies, are not the entire picture.
Okay.
There are other mechanisms other than just the antibody itself. I mean, it's reassuring when you have them. It doesn't mean because you don't have them that you're not potentially vaccinated appropriately. There are T cells. We always think about the B cells, but there are also T cells, and there's something called T memory cells, which basically memory T cells that basically may remind you that you've been exposed to that before and may still be able to trigger antibodies at that point in time. So, okay.
Okay. Do you recommend MESTINON be taken after eating? This person says they generally take it prior to eating to assist with swallowing. What are the ramifications of taking before eating?
Okay. I mean, it depends. Number one is how well do you tolerate the MESTINON? I have patients that never take it with food, and they have no side effects. And they do great. That's fine. The challenge is the patient have difficulty swallowing, but the difficulty is that, I mean, they may get their pills down, then they're going to have to wait 45 minutes or so for that MESTINON to kick in order to eat. That may be the circumstance, but you have to be, it's kind of a balancing act, because if they also happen to have a fair amount of nausea with their medication, they may need to take it with at least a little bit of food.
All right.
Even something like crackers or something, which easily, you can break that down pretty easily.
Mm-hmm, mm-hmm. All right. This person says, I take prednisone 20 milligrams at 9 in the morning and 20 milligrams at 9 at night, totaling 40 milligrams a day. This was the schedule I continued from the hospital. Will there be any side effects or exacerbations switching to 40 milligrams once a day?
So asking me a question that's something I would never do. So basically, there's no reason to give prednisone more than once a day.
Okay.
For myasthenia. So, and actually, the more frequent that you give it, the more likely to have side effects. So I think just take the 40 in the morning, not to mention when you take it in the evening, a lot of patients have difficulty sleeping because of the fact that you're taking prednisone tends to rev people up a little bit. So I just have patients just take it all in the morning. Okay.
Would you prescribe PLEX, PLEX, more frequently for a patient who is not a good candidate for steroids or immunosuppressants due to comorbidities?
Because of?
Comorbidities, sorry.
Yeah. Have I? Yeah. I mean, absolutely. I mean, again, is it my first choice? No. But if patients, I have patients who have melanoma and they got diabetes, for example. Okay, so they can't get prednisone, they can't get Imuran, CellCept, Prograf, or any of those medications. Well, your choices are MESTINON or try and do other things. And if for some reason they can't get IVIG, then plasma exchange is I mean, I have some patients, not a lot. I have a small number of patients, probably 10 or so, maybe less than 10, that are on plasma exchange on a regular basis. Due to, and some had to do with, again, their comorbidities. I had a couple that just didn't tolerate IVIG. And between, sometimes that's the default choice based on all of their other choices that you might have had that are not available to them.
Okay. And I apologize, Linda, I missed this. She put in, I had a thymectomy in 1975 and I was in remission until 1998. Now on MESTINON and doing great, had both Pfizer vaccines, had antibodies tested and it came back negative, had a third booster and it still shows low antibodies. What do I do to feel safe?
The only medication they're on is MESTINON?
Apparently so, that's what she put in.
Yeah, again, when the antibodies are present, it makes us feel a lot better. We know you have some immunity. The lack of or low levels of antibodies doesn't necessarily mean that you're not immune. It does not necessarily confer that you don't have significant immunity. So, I mean, and unfortunately, there's no way to test T cells on a commercial basis that can make it easy to say, oh yeah, you have these memory T cells that look great. Okay.
All right. I do not see anything else. Oh, we have one that just popped up. I have to be hospitalized numerous times. I've had to been I cannot speak. I apologize. I have had to been hospitalized numerous times since July, doing PLEX treatment since. I am CellCept. I'm on CellCept, MESTINON, and 50 milligrams. of prednisone. The only thing I have is diabetes. Is that too much PLEX?
Timing of PLEX depends upon the symptoms.
Okay.
I mean, it really comes down to, how long is it actually helpful? I actually have one patient who's getting it basically weekly. Am I happy with it? No.
Mm-hmm.
But the reality is, if they go 2 weeks, they get worse. So what do you do? I mean, as you're trying to optimize their other medications,
Mm-hmm.
and you're waiting for their thymectomy to kick in, and you're waiting the other. So you have to weigh everything and make that decision as to how to best approach that. I mean, they said they're on MESTINON. Now the question, I would say, my first question I would ask is, are they on enough MESTINON? Sounds probably not. I mean, some people like to be very skimpy with it, and that's their choice. But the point is that a little higher dose might actually bump up the benefits significantly. The prednisone did what it's going to do,
Mm-hmm.
and the CellCep depends on how long you've been on it. I mean, CellCep we talk about in the realm of 2 to 6 months at a dose to become effective. But if you start at 500 twice a day and you have to get to 1500 twice a day, I'll usually go 4-month increments. If there's no benefit on them, I'll eventually get them up there, but it still may take a year or more to get the benefits from that. And if they're antibody positive,
Mm-hmm.
Soliris should be in the consideration as well. Also, you consider rituximab as well. So
she typed in, I think she meant to say 60 milligrams twice a day, not 50.
What's that?
I think she re-entered 60 milligrams twice a day. So I think she meant.
MESTINON 60 twice a day?
Is that what you're saying, Susan? Yes.
Okay.
And she's seronegative.
Yeah. 60 milligrams, for most MG patients, 60 milligrams twice a day, if they're symptomatic, is not enough. MESTINON does not last, and even if you're taking 8 hours apart, 12 hours apart, MESTINON for some patients lasts every 3 hours, some last 4 hours. Again, this is not free advice. Go ahead and do it without talking to your doctor, just so we understand. But I would probably, if it were my patient, I'd probably go to 3 times a day, have them do that for a few days. That's not enough. I'd go to 4 times a day, but I can tell you twice a day is probably, that's probably part of the issue, symptom-wise. It's just twice a day MESTINON is not, in most patients. I have a few that are really good, have minimal, if any, symptoms, they can get away with 2 a day. But if someone's symptomatic, I don't know of any patient I have that can get away with only 2 a day and be sufficient.
Okay. There's so many different parameters to this disease. Everyone it's so different. It's very complex. I asked Tracy in the chat if she did have a question, but she just typed in, she's in Spain. She's seronegative. She's got swallowing, breathing, and voice issues and muscle weakness. She's on MESTINON and deflazacort for now.
Now, the deflazacort is hard to get here. It's a steroid.
Okay.
The original thought was, and actually it was originally used for Duchenne muscular dystrophy as a steroid.
Mm-hmm.
And the idea was it was going to cause a lot less side effects. The reality is you're trading one side effect for another. There's really not a significant difference between the two in terms of particular, they both have a bunch of side effects.
Okay. What heartburn medicine would you suggest for prednisone and MESTINON usage?
What?
What heartburn medicine do you suggest for prednisone and MESTINON users?
Well, MESTINON really shouldn't cause reflux per se, but prednisone certainly can. Again, depending what your other medications are, either a medication like Pepcid, and if that's not working, I'd probably go to a Prolosec or other similar medication. The 2 different classes of medication to see if that would be helpful. Again, make sure you take the prednisone after you eat. That's really key.
Okay.
I tell patients, regardless of why they're actually on the prednisone, take it after you eat. Just reduce the chances of side effects.
Do you ever use MESTINON? Do you ever use MESTINON ER more than once a day? I'm not sure what
I understand. I rarely use the time span at all. And the reason is that there's erratic absorption from the GI tract. So you don't always get a consistent dose. Well, how are you supposed to adjust a medication, which is variable in how much you're actually getting? Patients who come in on one or more doses a day, initially I may let them continue their nighttime dose until we get to the point, and with the idea that we're eventually going to try and get them off of it. So.
All right. How do you feel about immune boosters like zinc and various immune supplements, especially as we try to prevent and fight COVID?
I'm not so sure there's definitive evidence as to whether those help. I
know zinc is all over.
Yeah, I think you have to be careful. If you take too much zinc, you actually can develop a copper deficiency.
Okay, add that to the list. Okay.
Yeah. That could be, it may actually make things even worse than where you're at. Yeah.
Oh my goodness. Okay. Does the MESTINON work mainly on eye droop, or will it do anything for muscle weakness in legs?
Okay. So most muscles respond pretty well to MESTINON. The ones that are least likely going to respond are those related to ptosis or eyelid or the eye muscles.
Okay.
So those are the ones where you might have to use something other than MESTINON. I mean, I've had patients that have had pretty severe disease. They actually responded really well to MESTINON, and yet the eyelids just never budged until we put them on an immunosuppressant. That's not uncommon.
Okay. All right. Do you see a lot of, and I apologize if I can't pronounce this, dysautonomia, POTS as a comorbidity of MG?
They talking about dysautonomia POTS? Is that what you're saying?
Yes.
Yeah. Some dysautonomias / POTS are autoimmune in nature. So just like this increased risk of rheumatoid arthritis, autoimmune thyroid disease, certainly it's probably a little more common. It's not, most patients don't have it, but there are some that definitely have an autonomic nervous system dysfunction of some form, but most don't. That's definitely not due to the myasthenia, but again, when you have one autoimmune disease, you're more likely to get a second one compared with someone who doesn't have one.
Oh, okay.
Getting the first one, so yeah.
All right. We've gone through quite a few, so I don't see anything else. We just got a lot of thank yous for your time. A lot of people love you, Dr. Weiss. Oh wait, hold on. Someone just came through. Seems like there are many who experience hypokalemia. Is there a reason or a mechanism for this?
May not be. It could theoretically be from prednisone. Also, when patients, often when patients are in the hospital, and what happens is they give them normal saline. Well, if you give normal saline and don't put a little bit of potassium in it, often their potassium will drop. At MG, non-MG, doesn't matter. I've seen a number of patients get put on IV fluids for a few days. The potassium's 4.5, and 3 days later it's 3.7. Now, if it's not a myasthenic, we don't worry about it. But for a patient who has myasthenia, we're going to push on that a little bit.
All right. Jacqueline just sent in, I'm on 120 milligrams of MESTINON 4 times a day from the hospital. Is this dose too high?
Depends upon what the symptoms are. We start getting to that dose, if you're having some difficulty still, then that may be about a point in time where you might want to think about adding one of the other medications. Again, it depends on what all the things we've talked about in terms of what choices we really do have. But I have patients on 120 milligrams 4 times a day. Do I like them on a lower dose? Yeah. I want to go back when you made a comment earlier. I think this is important. Not just for myself, but wherever you are around the country, is that there are a lot of nuances. And even the treatment guidelines that came out a few years ago, if you have any kind of complicated myasthenia, beyond the real basic, there's some patients, frankly, we give you 3 pills a day, you do great, have no symptoms. Those aren't the ones I get to see, but those are the ones, those patients, you really need to see someone who knows what they're doing with myasthenia. I mean,
sure.
you know, it's just, I mean, around the country, there are a lot of MG experts.
Mm-hmm.
But, you know, but especially if you're in an area where there is one or more than one, and you're seen by a generalist and you're not getting satisfactory treatment, it's not unreasonable to get another opinion.
Okay.
Maybe different
Be
nuances.
your advocate.
Well, again, there's different comfort levels. I have, you know, even in our area, there are neurologists who can handle the basic stuff, but they kind of go, well, the patient's not really tolerating MESTINON. I don't use CellCept very often. I don't use prednisone. I'm a little worried. Why don't you see the patient, take care of it? That's fine.
Mm-hmm.
I mean, but there are patients who do well. There's no reason we have to see those that are doing very well with minimal medication. But they're not, you know, they say about 15% of myasthenia is refractory. In addition to that, there are probably a pretty significant percentage that may not necessarily be refractory, but have fairly consistent symptoms. So.
Okay. All right. Can you become insensitive to MESTINON from use? I had a doctor tell me that if you take a high dose, you'll burn out your ability to respond to it.
And that's a theory.
Okay.
I understand what they're thinking, because that's why you prefer to treat the underlying disease if you can, but you have to weigh the risks and benefits of that.
Okay. All right. And I was making sure that we answered all of these questions because I do believe we have a scheduling issue with our next speaker. So I'm not sure if we're actually going to be able to hear from Dr. Robert Paul or not. So I just want to make sure that we got all of these questions in on time. So that's why I went over everybody. Let me just do a last call for questions. I think we made it through all of them, but okay, hold on. I have severe generalized MG, and it turns out I may be autistic as well. I have been intubated over a dozen times. I need to see a myasthenia gravis specialist. Generally speaking, Dr. Weiss, would your recommendation, I mean, you can always contact our MDA Care Center wherever you live, in wherever you live. I don't know who sent that in there, but I would definitely recommend hopping on mda.org. You can find a care center near you and get a neurologist, and then hopefully find someone that specializes in MG.
Yeah.
You're getting a lot of praises. People love you. They say, tell him he's one of the best I've seen in 20 years. People travel far and wide to come see you.
Just try to do our best with every patient.
All right. All right. And last question here. Is it possible that the original seronegative can later become seropositive or positive to a new testing?
Yeah, I mean, you have to be careful. I mean, every lab test has a potential false positive, false negative. You know, I typically don't repeat it if I'm confident with the diagnosis. I may add, you know, again, there are some patients I've added the LRP for that were seronegative because we didn't have that available before. But otherwise, I typically don't repeat it. And also, it's not a very good, it's not a good biomarker for disease activity. It's a good marker if you have the disease and you're antibody positive. It helps us quite a bit. But being antibody negative doesn't mean you don't have it. I mean, it just makes a lot of people uncomfortable.
Mm-hmm.
And also, you know, what most of the drug studies are done for the most part are done with seropositive, just because they want it, that way they can definitively decide, okay, we know, okay, the patient's antibody positive, okay, they have myasthenia. Where if they're seronegative, there's potential for, well, is it really seronegative or not? So.
All right. Thank you so much, Dr. Weiss, for your time. This has been an awesome talk. Thank you so much.